As we discussed in the introductory video on diagnosis, the DSM framework, while useful, has its limitations. And one of these is in categorizing milder mental health conditions where it often falls short. However, in classifying severe mental disorders like those marked by psychosis, the DSM aligns more closely with medical approaches. Psychotic disorders such as schizophrenia present with dramatic symptoms and often severe impairment, which might suggest a straightforward diagnosis. Yet, diagnosing schizophrenia spectrum disorders still brings significant challenges, especially when considering individual and cultural differences. One example of this difficulty lies in how we assess delusions, which can sometimes be culturally influenced. This can lead to ambiguity in determining where the boundary between typical cultural beliefs and psychotic symptoms lies. As a result, we often approach diagnosis with a blend of science and art, a careful balancing of observable criteria and an understanding of each client's unique context. Today, we're exploring the art of diagnosing schizophrenia. And while schizophrenia was first identified over a century ago, much about its causes remain uncertain. It continues to be one of the most misunderstood and stigmatized disorders. Together, we're going to walk through what we know, from symptoms and theories on its origins to current treatment approaches. Before we dive into symptoms, I'd like to share a quote by Patricia Deegan, which captures the spirit of our work in diagnosing and treating schizophrenia. The goal of recovery is not to become normal. The goal is to embrace the human vocation of becoming more deeply, more fully human. And this reminds us that diagnosis and treatment aren't about forcing individuals into societal norms, but about supporting each person in building a meaningful, fulfilling life. Schizophrenia is considered a spectrum disorder, meaning that it includes various related conditions that share symptoms but may have different causes and levels of severity. Disorders on the spectrum include schizophrenia, brief psychosis, brief psychotic disorder, schizophreniform disorder, and delusional disorder. And while we could discuss schizotypal personality disorder here, it would be covered more in depth in our personality disorders lecture also in this module. So, symptoms of schizophrenia may vary widely between individuals, making early detection challenging. Initial signs can be subtle, such as mild personality changes, irritability, or a gradual shift in thought patterns. For a schizophrenia diagnosis, a client must display at least two core symptoms for at least 1 month: delusions, hallucinations, disorganized speech, abnormal motor behavior, and negative symptoms like diminished emotional expression or motivation. And at least one of those symptoms must be from the first three categories. Additional criteria include social or occupational dysfunction and total illness duration of at least 6 months. So, if this all sounds like a jumbled mess of things, go check back, read that chapter in your DSM, and follow along with me because we're going to talk about symptoms and criteria as we continue to go here. So, symptom types: there's positive, there's negative, there's cognitive. Positive symptoms include delusions, hallucinations, disorganized thinking or behavior, and these are called positive because they are present in individuals with schizophrenia but absent in the general population. So we're adding something here. One common misconception is that schizophrenia involves multiple personalities, but these symptoms are actually disruptions in thought processes. And as far as negative symptoms, these represent qualities that are diminished, such as motivation, emotional expression, and speech. As far as cognitive symptoms, clients may experience difficulties with concentration, memory, and decision making, which may impact daily functioning. Typically, schizophrenia emerges in early adulthood, late teens to early 20s for men, and late 20s to early 30s for women. The first psychotic episode often marks the onset of these positive symptoms, which may be shocking and disorienting for clients and for their families. Let's start by clarifying the term delusion. It is often misused in public. People may describe somebody as delusional for holding a strong belief that they disagree with. But clinically, delusions are defined as fixed false beliefs. Distinguishing delusions from strongly held beliefs can be challenging, especially with cultural nuances. According to the DSM 5TR, delusions are convictions that remain firm even in the face of contradictory evidence. Cultural beliefs, however, do not qualify as delusions if they're widely accepted within that cultural or religious context. So it's important to note that no clear guideline exists for distinguishing normal religious beliefs from pathological religious delusions. Historically, views like Freud's labeled all religious beliefs as delusional, while DSM-4 categorically exempted religious beliefs from being considered delusions. Today, we take a more balanced approach, assessing delusions by examining the conviction, preoccupation, and level of distress rather than the content of the belief itself. So, for instance, I once worked with this client who had been previously diagnosed with schizophrenia. And after a history of substance use, she had reconnected with her faith and found great comfort in her belief in Jesus. And this was initially very healthy and fulfilling for her, but she eventually began to believe that she was the Virgin Mary and that Jesus was her son. And what suggested that this was a delusion and not was not just the content, but the degree of preoccupation. It consumed her conversations, it caused distress in relationships, and was unsupported by her cultural context. Her church and her priests just didn't agree with her. So here we observed key features of a delusion: strong conviction, preoccupation, interference with daily life, and a lack of cultural endorsement. So there's different types of delusions. The first being grandiose. So that's exaggerated beliefs about self importance, such as thinking one is a religious figure or icon. There's persecutory delusions. So those are beliefs of being targeted or persecuted. And these often sound like they're all out to get me and can appear in various conditions beyond schizophrenia. Referential delusions are believing that unrelated events are directed at oneself, such as interpreting laughter as mockery. So maybe we have somebody, we'll just call him Joe, in a busy restaurant that overhears a bunch of people at another table laughing. A referential delusion would be the belief that this table is laughing at Joe, believing that they're making fun of him or discussing him in a negative light. Despite the fact that the group's laughter may have had nothing to do with Joe, Joe's referential delusion leads him to interpret it as a personal attack or ridicule directed towards him. And so this is something consistent that would be happening often. Erotomaniac, this is the belief that somebody is in love with the individual, often without any basis in reality. So I used to work as a barista, and I had this daily customer that believed that the latte art that I made in his cup meant that I was in love with him. And I just really liked making latte art. It was pretty fun to do. I did it for everyone. And I was not in love with him or any of my customers. And there was no amount of contrary evidence I could provide to this man that allowed him to believe anything other than the latte leaves were a love letter to him. So I stopped putting them on his lattes, and it didn't change his beliefs. He would associate some other meaningless thing to be a symbol of my love, like that my hair was in braids that day or that I wore a red shirt one day. Again, nothing to do with him at all. It was just how I was moving through my life. He decided that it all meant that I was in love with him. Then there's nihilistic delusion. So that's the feelings of non existence or impending destruction. So, for instance, a client may believe that their body or their identity has been erased. And then somatic delusions involve bodily sensations or functions like feeling insects crawling under the skin. So it's crucial to differentiate somatic delusions from symptoms induced by substances or other medical conditions. So, as we talk about symptoms across the spectrum from normal to abnormal, you might be thinking, wait, does this mean I'm delusional? Maybe you thought your barista was in love with you, or you saw a rainbow and felt that it was a sign from a higher power, or recently wondered if a group was laughing at you at lunch. These experiences are common, and almost everyone has moments of wondering, was that really happening or is it all in my head? And the distinction lies in conviction and belief despite contrary evidence. So delusions are marked by an unshakable conviction and an inability to see alternative perspectives, even when faced with contradictory evidence. For instance, if you think back and say, oh, maybe that car that seemed to be following me on the highway was just a coincidence, you're showing the flexibility of thought that delusions lack. So, social media and pop culture also often misuse that term delusional. Having an unpopular or highly personal belief does not make you delusional. Feeling that somebody might be flirting or personalizing a social encounter a bit more than others also doesn't meet clinical criteria for delusions either. In essence, we all experience beliefs that might stretch reality, but the presence of self doubt and alternative explanations keeps these beliefs grounded in reality. Delusions, however, remain unmovable and lack this internal flexibility, making the distinction between what's true and what isn't, and what's more complex for those experiencing them. So, if you want to do a little bit of a hunt on social media, type in uh, a couple search terms like schizophrenia or delusion and see if what you're finding on the internet and what the influencers are saying about these terms, see if it's accurate and grounded in what you know is existing in the DSM, in the research that's out there, because likely it's not. We want to be very careful about the diet of our social media content, but we also want to be very careful about what our clients are seeing and what our clients are searching for. So sometimes talking in a therapy session about, their diagnosis and what they've been seeing on the internet about it, providing some psychoeducation of what it is and what it isn't can be really helpful and really help them destigmatize what's going on with them. So we've covered delusions, fixed false beliefs. Now let's look at hallucinations, which are sensory experiences that feel real but occur without any external stimuli, typically while somebody is fully awake. So, unlike transitional states like falling asleep or waking up, where experiences can be vivid but don't count as diagnostic criteria, hallucinations in schizophrenia are experienced during alert awareness and without substance influence. So there's different types of hallucinations. Auditory is hearing voices or sounds that aren't there, most common in schizophrenia. And these voices often feel distinct from personal thoughts and are perceived as external. So it's not that inner thought dialogue, it's something external from the person. Visual hallucinations are seeing things that aren't present. Olfactory, gustatory, and tactile. So less common but possible, like smelling non existent odors, tasting something unusual that isn't really there, or feeling sensations like bugs crawling under the skin. That's the tactile one. And that's also something that I looped into delusion. So it sort of depends on how it's impacting the person, whether it's a delusion or hallucination for that tactile one. So, if hallucinations are likely due to a medical condition such as Parkinson's, Alzheimer's, clients should be referred to medical professionals for a comprehensive assessment. It may not be that they have schizophrenia at all. A lot of things can go wonky in our brain wiring. Assessing hallucinations can be nuanced, especially since clients may not immediately recognize these experiences as unusual or may not understand terms like delusion or hallucination. They might see these experiences as part of the reality and not something abnormal. For instance, a client who feels ants crawling on them may genuinely believe that this sensation is real and may be frustrated when questioned. So, to explore potential hallucinations sensitively, try questions that allow for openness, like, have you ever seen or heard something that other people didn't see or hear? Or have you had beliefs that are important to you, even if people who are close to you didn't share them? And these questions can yield valuable insights, not just about hallucinations or delusions, but also about a client's trauma history, social support, cultural beliefs, and substance use. In addiction treatment, for instance, hallucinations tied to substance use, like methamphetamine, are common. These are critical experiences to hear about as they inform the therapeutic approach, even if they don't indicate a schizophrenia diagnosis. So, one client I worked with believed that her teeth contained audio receptors during a meth binge. And she had this belief and she recognized it as false after she stopped using meth. However, the intense feeling remained, motivating her to seek treatment. Had I only asked about experience while she was sober, I would have missed this key moment in her story. So sometimes hearing the whole experiences are essential, even if it's connected to substance use and not a schizophrenia diagnosis. Disorganized thinking is often seen through speech that doesn't follow a logical flow, making it difficult for others to follow. This is different from occasionally changing topics or losing interest. This kind of disorganization is persistent and makes conversations unpredictable and hard to understand. Disorganized thinking is a core feature of schizophrenia, but can also appear in conditions like bipolar disorder during manic episodes. So, there's some different types of disorganized thinking in speech. The first one we're going to talk about is loose associations. This person's thoughts jump from one topic to another with minimal connection. Imagine starting a conversation about gardening, and then suddenly they're talking about something entirely unrelated, like trains, without any clear link. This is distinct from somebody who's changing topics intentionally, like somebody with ADHD who might change subjects because of shifting interests. Here, the connections are simply missing or incomprehensible. The next one's called derailment, or you might also hear it called as tangentality or tangents. This conversation keeps veering off topic, moving from one tangentially related idea to another without ever circling back. So, for example, if you're discussing food, they might shift from food to weight, then to inflation, all of which are loosely connected, but not really connected to the main topic and never really return to the main topic of food, like taking a detour that never brings you back to the original starting point. And the third one is called word salad. So, in extreme cases, speech can become word salad where words are strung together with no coherent meaning. It's not a foreign language, it's simply a jumble of words that don't form a meaningful sentence in any language. And this extreme disorganization is disorienting to the listener and really difficult to interpret. So, there are some cultural and religious considerations. It's crucial to differentiate disorganized thinking from culturally or religiously sanctioned practices. So, for example, speaking in tongues or entering trance states are accepted in certain cultural and spiritual practices. And here the difference is that disorganized thinking reflects disruption in cognitive processes rather than a perceptual experience like hallucinations or a culturally accepted ritual. So, in summary, disorganized thinking isn't just about jumping between topics, it's a disruption in the thought process that makes communication challenging and sometimes incomprehensible. So, by recognizing these distinctions, we're going to avoid misinterpreting culturally rooted expressions as disorganized thinking. Abnormal motor behavior in schizophrenia refers to goal directed actions that becomes disorganized or difficult to perform, interfering with daily activities. And this can range from unusual, purposeless movements to severe states like catatonia. Imagine the brain as a busy city with a traffic controller managing all the actions and movements necessary to get through daily life. In a well functioning system, this controller ensures that actions like brushing your teeth, walking to a destination, or even adjusting posture happen smoothly and with purpose. However, in some cases of abnormal motor behavior in schizophrenia, it's as if the traffic controller is misfiring, or maybe they just took the day off. They're sending cars in every direction without clear signals. And this misfiring can result in movements that seem purposeless, like pacing or repetitive gestures, even when they don't serve a goal. So, in severe cases like catatonia, the traffic controller might just freeze altogether, leaving that person immobilized in one position. And in this state, it's as though they've hit a red light and are stuck there, unresponsive, unable to move forward with goal oriented behavior. So, example is imagine if somebody was trying to prepare a meal. And instead of smoothly going from task to task, like cutting vegetables or stirring, they might find themselves suddenly stopping, staring, repeating a single action without completing the overall task. So it's not a matter of disinterest. It's as if their brain's ability to keep things on track has sort of short circuited, making it hard to get from one step to the next. So, just talking about catatonia a little bit more, it's the state of immobility where the person may hold a rigid or odd posture, appearing as though they're frozen in place, unresponsive to instructions. Unlike oppositional behaviors or conditions like mutism, catatonia involves complete lack of response and can include resistance to movement, known as waxy flexibility, where limbs stay in positions that they're placed in by others. Then there's that purposeless or excessive motor activity. So some individuals may display excessive, non goal oriented movements like pacing, agitation, or repeated gestures that don't serve any purpose. And then there's also what we call stereotype movements. And these can include repetitive actions such as staring, grimacing, or echoing others' speech. And stereotype movements differ from those seen in autism spectrum disorder like stimming or tic disorders or involuntary movements of tardive dyskinesia. So, abnormal motor behaviors in schizophrenia need to be differentiated from other causes. It is often seen in clients taking antipsychotic medications, and that includes involuntary facial movements like lip smacking, tongue thrusting, rapid blinking, caused by long term medication use. So, some medications, particularly those affecting serotonin levels, can also contribute to these side effects, which is why careful medication management is important in treatment. And we're not prescribers, but understanding these potential side effects provides some context for what clients might be experiencing and how we can diagnose what's going. Negative symptoms in schizophrenia are distinct from the positive symptoms like hallucinations and delusions because they reflect a reduction or absence of normal functions. So these symptoms can deeply affect daily life and often persist even when positive symptoms are controlled. So let's go over some of the negative symptoms. The first one is flat affect. So that's a limited display of emotions such as reduced facial expressions or vocal inflections, making the individual appear emotionally unresponsive. Avolition is a loss of motivation or difficulty in initiating and sustaining goal directed activities. So, tasks like personal care, hobbies, or work can become overwhelming. Anhedonia is reduced ability to feel pleasure in previously enjoyable activities, leading to disinterest in social interactions or hobbies altogether. And then social withdrawal is a tendency to isolate oneself, avoiding social situations and relationships. Elogia is also just called poverty of speech, and that's characterized by reduced speech or difficulty expressing thoughts. And then cognitive deficits, and that's impairments in memory, attention, problem solving, which impact functioning in work, school, and independent living. And if you're hearing these negative symptoms and you're saying, like, wow, that sounds a lot like depression, these symptoms can also be present in depression too. So, we need to be making sure that we're collecting a really good history to see if it's just the negative symptoms, if it's mood related, or if maybe there's positive symptoms in the mix too. And I want to talk to you a little bit about the antipsychotic medications. So, the medications are highly sensitive to blood plasma levels, meaning that dehydration can destabilize their effects. So, when dehydrated, a client may experience medication fluctuations that could lead to a return of active symptoms. And this can be especially common in warmer weather or for individuals with limited access to clean water, such as those experiencing homelessness or working outdoors. So, dehydration alone can lower mood, but combined with medication sensitivity, it's critical to monitor hydration. So, as we talk through this, just take a moment for just a personal reminder for yourself. Hydrate, drink some water right now. Even if you have to stop this, pause it, go get a glass of water, come back, restart. Make sure you're drinking water. Make sure your clients are drinking water. And if you're assessing a client, ask them about their hydration habits and consider their environment and access to water, particularly in summer or hot climates. So, now that we've covered the symptoms, let's look at the three related disorders on the spectrum. So, it's schizophrenia, schizophreniform disorder, and brief psychotic disorder. And these disorders form a continuum where each one represents a different duration and intensity of symptoms. So, unlike some disorders diagnosed on a continuum of severity, like mild, moderate, or severe, psychotic disorders use distinct terms to indicate stages along the spectrum where the key differences lie in how long the symptoms last and the impact on daily functioning. So, starting with brief psychotic disorder, this is the shortest duration, lasting less than 1 month. This disorder involves sudden onset of psychotic symptoms like delusions or hallucinations, but resolves relatively quickly. So, imagine it like a flash of lightning, intense and disruptive, but short lived. Next on the spectrum is schizophreniform disorder. So this lasts 1 to 6 months. So think of it like an extended storm. It's lasting longer than the brief psychotic disorder, but may not bring the lasting life disruption associated with schizophrenia. Some symptoms may fade or respond to treatment, preventing full progression. And then schizophrenia is the longest lasting. So that's going to be 6 months or more with marked declines in functioning. Schizophrenia not only involves prolonged psychotic symptoms, but often brings significant changes in how a person functions in daily life. And this can be thought of as a long, severe winter where persistent symptoms may make it difficult for the person to engage in life as they did before. So, while two or more symptoms, like delusions, hallucinations, disorganized speech, or negative symptoms, need to be present for all three disorders, the time frame is what is essential in the diagnosis. So, brief psychotic is less than 1 month, schizophreniform is 1 to 6 months, schizophrenia is 6 months or more. So, this is often with noticeable decreases in functioning. So, it's important to rule out other medical and psychological conditions that can cause similar symptoms. Neurocognitive disorders such as dementia, mood disorders like bipolar disorder can present with hallucinations, delusions, and disorganized thinking. Additionally, substance use may contribute to these symptoms, so a thorough assessment is crucial. So, what causes the onset of psychosis? The development of schizophrenia and psychotic disorders likely stems from an interplay of genetic and environmental factors. So, here's what we know. Schizophrenia has one of the strongest genetic components of any psychiatric disorder. While only 2% of the population is affected by schizophrenia spectrum disorder, children or siblings of somebody with schizophrenia have 10 times greater risk, And identical twins have a 40% chance of developing it if one twin is affected. And research has linked various environmental and lifestyle factors to an increased risk of schizophrenia. So, trauma and chronic stress comes up quite a bit. So, childhood trauma, social isolation, chronic stress are significant risk factors. So, when we talk about adverse childhood experiences, there is definitely a connection here. Additionally, living in urban areas is associated with a higher incidence of schizophrenia regardless of socioeconomic status. And while specific causes aren't fully understood, potential factors could include constant noise, light exposure, and heightened stress from just living in an urban setting. There's also substance use to consider. So, cannabis, particularly high THC strains, and synthetic marijuana or something like K2, can increase the risk of psychosis onset, particularly in genetically susceptible individuals. And then there's also a factor about maternal vitamin D deficiency. So, prenatal stress, early life infections can also contribute to schizophrenia risk with individuals. So, oftentimes when taking a history, we want to start at the very beginning, or we even want to look at family history of what was your mother's role? What was the neonatal period like? And then additionally, when we're looking at neurotransmitters, the dopamine imbalance was thought to be the primary cause at first, with antipsychotic medications targeting dopamine 2 receptors to reduce hallucinations and delusions. However, recent research highlights the role of other neurotransmitters, especially glutamate, which is associated with the brain's response to stress. So, elevated levels of glutamate and its related compound glutamine have been found in individuals with a family history of schizophrenia, possibly linking stress and intergenerational risk. And some other neurotransmitters at play might be serotonin, norepinephrine, histamines, and acetylcholine. And there's also others under study as they play key roles in mood regulation, cognition, and stress response. So while schizophrenia may not be frequently encountered in general mental health or private practice, it is more common in higher levels of care, such as inpatient or partial hospitalization programs. So, settings like addiction treatment centers may also see higher rates as substance use can exacerbate psychotic symptoms or trigger episodes in susceptible individuals. So, approximately 2% of the population has a schizophrenia spectrum disorder, and that includes schizophrenia, that's 3 to 7 per 1,000 people. Brief psychotic disorder is 5 per 1,000. Schizophreniform is 1 per 1,000. Schizoaffective is 3 per 1,000, and delusional disorder is 2 per 1,000. So, counselors are going to play a vital role in assessing risk factors. We can help reduce the impact of trauma, social isolation, and addiction while supporting individuals in managing stress, connecting socially, and accessing nutritional resources. So, recognizing factors that increase stress, such as major life events like immigration, or urban environments allows us to tailor interventions that ease the stress and prevent the buildup of neurotransmitters like glutamate. This, in turn, may help lower psychosis risk in those who are vulnerable. Schizophrenia impacts many aspects of daily life and often comes with heightened health risks and cognitive challenges. To support individuals with schizophrenia effectively, it's essential to address both physical and mental health needs while adapting our interactions to accommodate cognitive and sensory limitations. People with schizophrenia face increased risks for diabetes and cardiovascular disease, partially due to lifestyle factors like smoking and, in some cases, side effects from antipsychotic medications. Secondary treatment goals should include encouraging healthy food choices and managing weight, monitoring blood sugar levels and cardiovascular health, and providing education on reducing smoking and engaging in regular physical activity. Anxiety, depression, and feelings of isolation are common. Many individuals also experience a grieving process after diagnosis as they come to terms with the condition and its implications for their life. Acknowledging and supporting clients through this emotional process can be as important as addressing their immediate symptoms. Schizophrenia often impairs cognitive abilities such as organizing thoughts, remembering information, and maintaining focus. And so, to help our clients navigate these challenges, we want to use concise communication, offer short, clear instructions, and break tasks down into single steps. Provide written instructions. Avoid relying on memory by writing down information and directions, and limit session length. In group settings, keep sessions brief. 20 to 30 minutes is often optimal to maintain intention and engagement. Long or complex sessions can lead to cognitive overload, We also want to minimize distractions, so avoid high stimulus environments. So, for example, avoid holding sessions in noisy or crowded areas, as individuals with schizophrenia often struggle with sensory gating, making it difficult to filter out extraneous sights and sounds. And employment can also be challenging for individuals with schizophrenia, but part time, volunteer, or supported work with understanding supervisors can offer structure and purpose. Socially, clients may struggle with reading interpersonal cues and often lack a supportive network, contributing to feelings of isolation and increased risk of depression or suicide attempts. Building a supportive environment and fostering social connections can be instrumental in improving quality of life. And we already talked a little bit about differential diagnoses, but I want to make sure that we're talking about them specifically. So, a diagnosis of schizophrenia requires careful exclusion of other psychological and medical conditions that can cause psychosis. Differentiating schizophrenia from these conditions can be complex as they're overlapping symptoms and there's subtle distinctions. So, when we talk about schizophrenia versus schizoaffective or mood disorders, affective disorder and mood disorders with psychotic features. So, if hallucinations or delusions occur only during a major mood episode, such as major depression or mania, the diagnosis may lean towards a mood disorder with psychotic features rather than schizophrenia. Schizophrenia requires psychotic symptoms, hallucinations, delusions in the absence of a major mood episode. So, first questions are about the mood episodes, if they're happening at all. And if they are, is that when the hallucinations and delusions are happening, or are they happening at all times, even if the mood episode isn't happening? So, negative symptoms in schizophrenia, like flat affect, avolition, can mimic symptoms of a mood disorder, like I was describing before, making this distinction challenging. So, careful assessment is needed to determine if psychotic symptoms persist independently outside of mood fluctuations, supporting a diagnosis of schizophrenia. Then there's schizoid personality disorder that we'll talk about in the personality disorder lecture. And the differences here are that schizoid personality disorder involves detachment from social relationships and restricted emotional expression without the active psychotic symptoms of hallucinations or delusions. So, while the term schizoid means split or break, it refers here to a break from social connection, not a break from reality like schizophrenia might be. So, this disorder lacks the disorganization and reality distortions characteristic of schizophrenia. We're also going to look at bipolar disorder with psychotic features. So, psychotic features in bipolar disorder often appear alongside manic or depressive episodes and may not lead to the same level of chronic psychosocial dysfunction seen in schizophrenia. In bipolar disorder, social functioning typically returns between episodes, whereas in schizophrenia, that often involves more persistent impairment across all areas of life long term. And then last week, we talked about the major cognitive disorders like dementia, early onset Alzheimer's, and those can also present with delusions or hallucinations. If the psychotic symptoms have rapid onset, especially in older adults, neurocognitive disorders should be considered. So, possible diagnoses here would be the major neurocognitive disorder with and treatment often focuses on medical management rather than psychiatric interventions typical for schizophrenia. So, rapid assessment and interventions are crucial to maintain quality of life and slow progression of the neurocognitive conditions. We have substance or medication induced psychotic disorder. So, psychotic symptoms induced by substances or medication are typically linked to the timing of substance use or withdrawal. So, symptoms tend to decrease as the individual distances themselves from the substance. So, if hallucinations, delusions are high when substance use is going on, but then when a person gets clean and sober and isn't using substances anymore, we would likely expect that the hallucinations and the delusions of a person with a substance or medication induced psychotic disorder would decrease over time. There is always one exception to every rule in the book, though. And this one's really interesting because I'm seeing this a little bit more with my current caseload. There's something going on with the hallucinogens in the system right now. So this one's called hallucinogen persisting perception disorder, or HPPD. So hallucinogen persisting perception disorder is a condition characterized by the reoccurrence of perceptual disturbances such as visual hallucinations long after the hallucinogenic substances have been used and cleared from the system. So while traditionally associated with LSD, this disorder has been linked to other substances lately, including synthetic cannabinoids. So, recent analysis indicate that hallucinogen persistent perceptual disorder is considered rare, with previous estimates suggesting it occurs in 1 in 50,000 hallucinogen users. However, a more recent web based questionnaire found that 4.2% of just shy of 2,500 surveyed individuals described persistent visual phenomenon post drug use associated with clinically significant distress, which would be consistent with a diagnosis of hallucinogen persisting perception disorder. So, this suggests that this might be more common than previously thought and not exclusively linked to LSD use. Unlike typical substance use psychosis, these symptoms may persist for years, decades. So, careful assessment of substance use history is crucial to differentiate between substance induced psychotic symptoms in schizophrenia and hallucinogen persistent perception disorder. It's a mouthful. Next one that I want to talk to you about as far as a possible differential would be PTSD with psychotic features. So, PTSD can include dissociative symptoms, intrusive thoughts, and even psychotic features like hallucinations, particularly in severe cases. The distinguishing factor here, though, is that the presence of trauma history is key. PTSD symptoms are often directly tied to trauma related triggers, and psychotic features are more commonly brief and related to flashbacks or intense distress, unlike the persistent psychosis seen in schizophrenia. We might also consider borderline personality disorder with brief psychotic features. And so, individuals with borderline personality disorder may experience brief stress related paranoid ideation or dissociative episodes that resemble psychotic symptoms. Psychotic symptoms in borderline are typically transient, triggered by acute stress, and not pervasive. Also involves instability in self image, relationships, and mood, which are not the core features of schizophrenia. There's another interesting one here that is obsessive compulsive disorder, OCD, with poor insight. So, severe OCD can involve intrusive, distressing thoughts that may be mistaken for delusions, especially if the person has poor insight. So, in OCD, the intrusive thoughts are recognized by the individual as irritating or distressing, even if they struggle to control them. Schizophrenia, on the other hand, involves a more fixed belief system without the same level of insight into irrationality of thoughts. Dissociative symptoms and disruptions in identity can sometimes mimic aspects of disorganized thinking or unusual perceptions. Dissociative disorders typically involve alterations in memory, identity, or consciousness rather than sustained psychotic features like delusions or hallucinations. So, history of trauma is also common in dissociative disorders. And the last one that I want to talk about here is epilepsy, especially temporal lobe epilepsy. And this is pretty rare, but it's still worth noting. So, epilepsy, particularly the temporal lobe one, can produce hallucinations, altered perceptions, and intense emotional experiences that might resemble psychosis. So, hallucinations in epilepsy often have a stereotyped, repetitive quality, are brief, and associated with seizure activity. So, an EEG or a neurological evaluation can help differentiate epilepsy from schizophrenia. Differential diagnosis for schizophrenia requires careful evaluation of the timing, persistence, and specific nature of the symptoms. It's essential to rule out conditions that may present with similar symptoms, including mood disorders, neurocognitive disorders, substance induced psychosis, personality disorders, PTSD, dissociative, and neurological conditions like epilepsy. Each of these conditions has unique features such as symptom duration, the influence of stress or trauma, insight level, and response to medical interventions that help distinguish them from schizophrenia. And a comprehensive assessment of all of these factors will ensure accurate diagnosis and guide appropriate treatment planning. And here's the other part too that maybe we don't talk about enough yet. You're not alone. You're not on an island. You never will be. The weight of diagnosis does not have to rest solely on you. Use your supervisor, use your treatment team. There's peers to help you suss out symptomology. If there's ever multiple possible diagnoses in the mix that you're considering, make friends with a psychiatrist that can help you get a second opinion or a primary care physician. If it's schizophrenia, the likelihood that a client will need a psychiatrist on their care team will be high anyway. So let's introduce this person early and often to our clients to make sure that the entire treatment process is client focused and a team effort. Schizophrenia treatment has evolved significantly, now combining pharmacological, therapeutic, and psychosocial interventions to address both symptoms and underlying brain health. This comprehensive approach aims to improve quality of life, decrease symptom recurrence, and address long term health impacts. So, first, we're going to talk a little bit about medications, and we're going to talk about the traditional or the first generation antipsychotics. So, early antipsychotic drugs like Halidol and Thorazine primarily block dopamine receptors, reducing positive symptoms such as hallucinations and delusions, which are linked to excess dopamine in specific brain circuits. However, these medications can sometimes worsen the negative symptoms, possibly due to reduced dopamine activity in other areas like the prefrontal cortex, where dopamine plays a huge role in motivation and mood. Atypical or second generation antipsychotics. So these are the newer antipsychotics. This is risperidone, Zyprexa, Abilify. You might have heard of some of these from commercials. And these target multiple neurotransmitters, particularly dopamine and serotonin. So, by balancing dopamine levels more broadly across the brain regions and adding serotonin regulation, these medications aim to lessen both positive and negative symptoms while potentially fewer motor side effects. However, side effects such as weight gain, metabolic changes, and increased cardiovascular risk remain significant concerns, highlighting the need for individualized treatment and regular monitoring. If you're on a treatment team for somebody with schizophrenia, you might want to consider adding a PCP or a primary care physician in the mix to that team. Research shows that some people with schizophrenia experience brain tissue loss, particularly in areas involved in higher order thinking and emotional regulation. So it's unclear whether these changes stem directly from schizophrenia, are influenced by long term medication use, or a combination of both. Some studies suggest that untreated psychosis may accelerate neural atrophy, reinforcing the importance of early and consistent treatment to reduce repeated psychotic episodes. Emerging research supports that untreated psychosis have effects similar to repeated concussions, potentially creating long term vulnerabilities in brain structure and function. And there's some therapies that we might want to consider from the counselor side. So, cognitive behavioral therapy helps clients reframe distressing thoughts, manage symptoms, improve coping skills. This therapy can be especially useful for managing negative symptoms and helping clients re engage in their daily life. Electroconvulsive therapy is used in cases where medications and other therapies have not been effective, particularly when catatonia or severe depression co occurs with schizophrenia. Recent studies show that electroconvulsive therapy effects are often short lived. It can be a useful bridge therapy, reducing symptoms long enough to allow for other treatments to take effect. And like I've been saying, early intervention is crucial. Studies show that longer durations of untreated psychosis are associated with poorer outcomes, as untreated episodes can reinforce neural pathways associated with psychosis, making symptoms harder to manage in the long term. In some cases, untreated psychosis may embed itself in a person's personality or coping mechanisms, creating a cycle of repeated symptoms. So, reducing the stigma associated with schizophrenia and schizophrenia treatment is essential to encourage earlier treatment and promote long term recovery. Finally, just a quick reminder, stay hydrated. Antipsychotics, especially in those sensitive to blood plasma levels, can be affected by hydration. Dehydration can destabilize these medications, leading to fluctuations in symptoms, particularly during warm weather or for clients who lack access to water. And this is especially relevant for individuals experiencing homelessness or those working outside. Regular hydration helps stabilize blood levels, supporting medication effectiveness and overall well being. And that doesn't just go for antipsychotic, that goes for anybody who has mood disorder diagnosis. So I want to talk to you about something that I don't think that we normally talk about too, and let's talk about some therapies that are not recommended for schizophrenia. So let's start with psychoanalytic or psychodynamic. Those therapies often focus on exploring unconscious thoughts, past traumas, and early life experiences. And while valuable in some contexts, these approaches can be counterproductive for many individuals with schizophrenia. So, diving deeply into the subconscious content may increase distress or confusion, especially for those experiencing delusions or disorganized thinking, where reality testing abilities are compromised. For clients with schizophrenia, focusing too intently on subjective interpretations or unconscious motivations may inadvertently reinforce psychotic thinking patterns rather than helping them to manage them. We also want to be mindful of exposure therapy, and that's commonly used to treat anxiety disorders by gradually exposing clients to feared stimuli. However, it's not generally effective for schizophrenia and could be harmful. Clients with schizophrenia may have heightened sensitivity to stressors, and exposure therapy can elevate anxiety, potentially triggering psychotic symptoms or worsening paranoia. Instead, gentler CBT based approach may reduce anxiety without direct exposure. Hypnotherapy involves introducing trance like states to access subconscious thoughts and promote behavior change. It's not suitable for schizophrenia. The altered state of awareness can blur the lines between reality and imagination, potentially worsening symptoms like hallucinations or delusions. The next one is client centered therapy without structure. And I know we talk about how great client centered therapy is, but the key here is the without structure. So, this therapy developed by Carl Rogers emphasizes unconditional positive regard, empathy, and allows clients to guide the direction of therapy. However, when used without structure for clients with schizophrenia, it can lack the necessary guidance and reality orientation. Individuals with schizophrenia may benefit more from structured approaches that include psychoeducation, skill building, and clear therapeutic goals. So, without the structure, sessions may feel directionless or confusing, potentially increasing disorganization or reinforcing the psychotic thinking. We also want to be mindful of the intensive trauma focused therapies. So, while many clients with schizophrenia have trauma histories, intensive trauma focused therapies like prolonged exposure or trauma processing therapies are typically not recommended during active psychosis or early stages of treatment. Addressing trauma too directly can overwhelm the client's coping abilities, possibly leading to symptom destabilization. Once clients have achieved stability, gentle trauma informed care may be integrated with caution, although often through approaches that build resilience and coping skills gradually. This one's super popular right now, psychedelic assisted therapy. So I want to make sure that we're talking about it a little bit more. Although psychedelic assisted therapy using substances like psilocybin or MDMA show promising results in some areas of mental health, they are generally contraindicated for schizophrenia. Psychedelics can profoundly alter perception, thoughts, and senses of reality, which may exacerbate symptoms of hallucinations and delusions or disorganized thinking in individuals with psychotic disorders. Research indicates that psychedelics can increase the risk of psychotic episodes or worsen existing symptoms in those predisposed or those diagnosed with schizophrenia. Therefore, altered states induced by psychedelics pose significant risks that can destabilize clients, making therapy unsuitable. And the next one that I want to talk about, sort of on the same vein, is cannabis or other psychoactive substances. Cannabis, although legal in most states and even therapeutic for some conditions, is associated with increased risk for individuals with schizophrenia. Studies have shown that cannabis use specifically at high THC levels can trigger psychotic symptoms, reduce the effectiveness of antipsychotic medications, and lead to earlier onset of schizophrenia in those who are genetically predisposed. Cannabis can also contribute to worsening cognition, memory, and executive functioning, all of which are already compromised in many individuals with schizophrenia. Other psychoactive substances, such as amphetamines or hallucinogens, can similarly destabilize mood, exacerbate delusions or hallucinations, and reduce treatment adherence. So, why does this matter? So, for schizophrenia, maintaining a stable sense of reality and reducing risk factors is essential. Psychedelics and other psychoactive substances can disrupt the stability, increasing the likelihood of psychotic episodes and hindering treatment progress. In contrast, structured therapies that focus on reality orientation, skill building, and gradual symptom management offer a safer, more supportive pathway for managing schizophrenia symptoms. So, wrapping up here, schizophrenia remains a deeply stigmatized condition, even among medical and mental health professions. So, let's take a moment to reflect on any preconceptions or biases that you might have working with this population. So you might want to take some time to maybe journal your thoughts here, but what do you already know? Don't you know? And what are you afraid of? Often the apprehension surrounding the work with certain populations comes from fear of the unknown. And as we move through this semester, we'll work to demystify these diagnoses, making the unknown a bit more familiar and helping to address and reduce some of these fears. I'm hoping today's lecture did a little bit of that so that you feel more prepared to treat the human not the diagnosis. People with schizophrenia are often perceived as dangerous, yet they are far more likely to be the victims of violence than the perpetrators. Proper treatment can reduce the likelihood of violence associated with this disorder, which is why education, both for clients and their families and their communities, is crucial to erode stigma and increase access to support. And as future counselors, what are some ways that you can think of to reduce stigma around schizophrenia? Schizophrenia affects each person differently. Some manage it independently, others may need supportive housing, and some might live with family or in group settings. Schizophrenia can impact one's ability to hold full time employment, highlighting its broader effects on communities as well as individuals. Preventative strategies should include nutrition, reducing stress related inflammation in pregnancy, and addressing stress in children and adolescents, which are potential risk factors. Adverse childhood experiences research reminds us that stress affects people from infancy onward. Early prevention and support for children and families may help mitigate some factors associated with schizophrenia risk, even though much remains unknown. So, we're going to continue to explore science, treatment, and support strategies to improve the lives of individuals with schizophrenia, keeping in mind that we still have a long way to go in understanding the full picture. For now, our goal is to expand our knowledge, challenge our bias, and find ways to advocate for and support those living with this disorder. Let me know if you have any questions. Please reach out. I am always happy to help.